Welcome to the third episode of Striking a Balance Between Effectiveness and Heart Health. In this episode, we're shifting the focus to action, how nurses can proactively assess, prevent, and manage cardiovascular risks in patients receiving BTK inhibitors for CLL. Listen as Anacita Fadal, PhD, APRN, from MD Anderson Cancer Center, and Hassana O'Neill, MHS, PAC, also from MD Anderson Cancer Center, two distinguished experts in hematology and oncology nursing, provide their real-world strategies for balancing effectiveness and cardiovascular safety, incorporating patient perspectives, and engaging a multidisciplinary team.
Hello, I am Anacita Fadal, and I'm joined today by my esteemed colleague, Hassana O'Neill. We are talking about a patient with CLL and was treated with BTK inhibitor. So, Hassana, what are the rational and practical steps for conducting cardiovascular risk assessment in patients with CLL before initiating BTK inhibitor therapy?
Thank you, Anacita. There are multiple things that are a part of our rationale in doing a pre-treatment assessment in these patients. Because of the high incidence of cardiovascular toxicities, it becomes quite important to make sure these patients are going to be able to tolerate and be aware of what we need to watch out for in the individual patients. With BTKIs, there's increased rates of atrial fibrillation, hypertension, heart failure, bleeding, ventricular arrhythmias as well. So that's important to continue to monitor for things like that. And you have to know when it's necessary to modify any of the dose, or if you need to interrupt or discontinue the therapy. Because the therapy may be contributing to some type of comorbidity or morbidity or mortality, I should say. So those are some of the rationale. In terms of our practical steps that we want to do with this pre-treatment risk assessment, we want to determine, their actual performance status. And that comes by using the ECOG, which is the Eastern Cooperative Oncology Group performance status assessment. That's so that we can assess their tolerance, make sure it's going to be feasible, and get a good idea of, what the outcomes may be in these patients who are going on the BTKIs. The other types of tools that we can use to validate any kind of side effects they may have are things like using our CHA2DS2-VASc score, using our atherosclerotic cardiovascular disease risk score. And these patients should normally get a baseline EKG and more than likely an echocardiogram as well, because in some of the first generation BTK inhibitors, there's a contraindication in using the medications or the first generation BTKIs for things like ibrutinib, if the ejection fraction is less than 50%.
Hassana, thank you for that explanation. So, what are the pre-treatment evaluation steps?
While they're receiving therapy, you are basically kind of going to break the roles up in terms of who's checking what and who's kind of doing the double checking. There's an aspect of roles that the APP, the physician assistant, or the nurse practitioner may have. So in the pre-treatment process, they're doing a history and physical. They're assessing the cardiovascular risk factors in that particular case. And this is through different office visits that the patient may have, especially in the pre-treatment setting. They would have a pre-treatment office visit, and if there are any symptoms, there may be subsequent office visits. They're also identifying any kind of bleeding risk, if they're on any medications such as antiplatelets or anticoagulation before and during this therapy when they start their treatment. You also want to ensure any pre-existing blood pressure issues that they may have, because you're going to be monitoring that blood pressure during the treatment time frame as well. And you also want to make sure of any kind of arrhythmias they may have had in the past, more specifically atrial fibrillation, ventricular arrhythmias, since those can be the side effects that we discuss. So this is all being done in our office visits. Whereas the role of the RN is more of course, triaging through doing blood pressure assessments, um, taking the blood pressures when they come in, talking to the patient and educating the patient regarding the different symptoms that may be occurring um, when they're not in our presence. So the patient should be aware of different symptoms, cardiovascular side effects that have to do with this particular treatment. And they should always be referring, the nurses should always be referring the serious symptoms and problems back to the APP or the physician in order to determine if further treatment strategies need to be involved. Nurses also effective in using the RNs are also very effective in teaching patients about keeping logs of their symptoms, keeping logs of their blood pressures, heart rates, different things like that, so that we can easily communicate between patient and provider or patient and RN what's going on in terms of any kind of side effects or adverse effects with the medication.
What are the practical guidance and tips do you have on red flags that nurses can watch for?
So when it comes to the APP, the APP is basically looking for the three main cardiovascular side effects that can occur with BTK inhibitors. And those include atrial fibrillation, hypertension, and bleeding are the major concerns. Now, with atrial fibrillation, in the office visit, the APP is going to assess, are there any new palpitations? Is the patient noticing maybe on their iWatch or their Apple Watch that their heart rates are going out of control or flashing that there's been some atrial fibrillation. And you also want to look at the EKGs and make sure if there's any changes to the EKGs that are occurring. If the patient is indeed having these symptoms or their EKG changes, you may need to order further monitoring, such as a Holter monitor. And if they're going to their cardiology or cardio-oncology APP, there may be even other types of monitors that we for longer term monitoring, such as event monitors that may be up to like 30 days, or implantable loop monitors that can be even further long term to assess for atrial fibrillation if you don't see them during those shorter time frames. Now, with blood pressure, that's an in-office as well as a home type of assessment. And what we want the patient doing is monitoring at home and bringing those logs in so that we can assess them. And if their blood pressure is consistently going above 140 over 90, definitely want to initiate therapy. And we're often initiating ACE inhibitors or ARBs, plus or minus thiazides, such as hydrochlorothiazide or chlorthalidone. Now, if the patient has other cardiovascular risks, we may consider using other antihypertensives versus using the ACE inhibitors, ARBs, and the diuretic thiazides. In terms of bleeding, your concern is with major bleeding, such as GI bleeding, bleeding that could cause strokes, arachnoid hemorrhage, severe headaches, things like that. That is often going to require a hold of the BTK inhibitors, possibly short term, possibly longer term in those particular situations. Now, when it comes down to the nurses or the RN's role in terms of these patients, again, they're going to be helping them monitor consistently their blood pressures, their heart rates, and their symptoms at home. They have to be consistently keeping the patient aware of which symptoms, palpitations, dizziness, headache, syncope, um, in order to help the patient understand what may be significant when it comes to cardiovascular risk. And of course, the nurses, again, as I mentioned before, are going to go ahead and refer to the APP or the physician.
Thank you for that detailed explanation of the role of the APPs and the RNs. So, how do you adapt these care plans based on the individual patient's risk factors?
So you're again using different type of risk assessment or assessment tools that help you individualize these these plans or care plans for patients. So the ECOG that I mentioned earlier, you're using the staging for CLL, you're using your risk of stroke assessment, that's the CHADS-VAS score for atrial fibrillation patients. You're using your cardiovascular risk score. And you're also looking at the individual risk factors that are cardiovascular, such as hypertension, vascular disease, history of coronary disease, diabetes, heart failure, prior stroke, or TIA. Um, if you have a patient who's actually dealing with high or has a high cardiovascular risk, you're usually going to choose more of a second generation BTK inhibitor rather than using this first generation. Also, if they have renal impairment, you're typically avoiding the first generation ibrutinib and because of the CYP the 3A4 metabolism that it has and the concerns with those patients in renal impairment. Now, for patients with a very low comorbidity, you still may want to choose your second, you still typically will choose your second generation BTK inhibitors because of the lower rates of atrial fibrillation and the lower cardiovascular toxicities when compared to the ibrutinib, which is our first generation. And of course, all this comes in sharing your decisions with the patient. It's not a one-sided decision. It is a team effort with the patient and the providers in terms of deciding which is the proper BTK inhibitor in that particular patient. The nurse's role again comes in further education, fall prevention because of bleeding risk, managing the hypertension and keeping logs and making sure they get transferred over to the physician or the APP. Also, making sure the patient's watching out for symptoms and reporting the appropriate symptom that they're having.
Thank you, for spelling out those specific roles of the APPs and the RNs. So, what is the role of the nurse in ongoing monitoring, managing, and patient education?
As a RN, you're again supporting the APP and the physicians in terms of these roles because they're watching out for the signs and symptoms of heart failure, bleeding, or ischemia. They're also monitoring the vital signs that we've mentioned multiple times. Um, for routine checks, they want to make sure if you have any concerns about heart failure, which can occur with our BTK inhibitors, you're looking for signs of heart failure like weight gain. Anemia can occur and the patient may have fatigue. So they want to monitor those types of things as well. Also, the response to the treatment and the adverse events are always important and essential to be aware of. So patients, you not only need to tell them, but you also want to use the teach back method. And that's where, the patient is actually teaching you in essence and telling you by you just reiterating, okay, so we talked about the different side effects and what you need to be doing at home. Can you tell me what some of those things are? And they're able to teach you, and that helps helps you to know that they're understanding. It's also important for the nurse to maintain excellent communication with the oncology APPs, oncologists, the cardiology or cardio-oncology APPs or the cardiologist or the cardio-oncologist in order to determine, again, further treatment and management in these particular patients. So the APP role when it comes to ongoing monitoring and managing the patient as well as education really falls in the follow-up. So intermittent office visits may be necessary. EKGs at 3-month intervals may be necessary. Following a lipid panel on an annual basis in order to manage cardiovascular risk is important. And the patient may also need intermittent echocardiograms, especially if they have any history of heart failure or is new onset valvular problems that are seen in our patients with atrial fibrillation. So their echocardiograms may need to occur at 3, 6, or 12-month intervals, depending on that individual. We also want patient-centered dosing when it comes to the BTK inhibitors. So if atrial fibrillation occurs, we have to think about needing to possibly reduce the dose, interrupt the BTK inhibitor at the time while we're getting control, or even a consideration of changing therapies.
So, how do you incorporate the patient's perspective into the treatment plan?
Again, shared decision making is vital, part of the APP role when you're in a visit with a patient. So you want to have them aware of the progression-free survival and kind of balance that with the trade-offs of their quality of life. So that's how you're sharing your decision in terms of what generation and the choice to go on therapy with BTK inhibitors, essentially. Now, on the side of side effects, you have to think about the impact of atrial fibrillation and the quality of life. So again, shared decision making in CLL treatment selection should always include informed decisions with the adverse effects that can occur from the treatment, the efficacy and the comparisons in the different generations, as well as the patients may refer to treatments with less impact of adverse side effects so that they can have a better quality of life. When it comes to the role of the RN, in this particular situation, they want to distribute the proper education to the patient. The NCC and guidelines for patients with CLL is done in 2025 is a comprehensive uh, piece of literature that gives patients full information from pre-treatment to side effects to lifestyle changes. It's an excellent resource for those patients. You want to make sure the nurse is assisting with appropriately triaging patients, especially when they call in with any kind of side effects or any kind of symptoms that they're addressing at the time. And they have to know when that is essential to be passed on to the oncology APP or the cardio-oncology cardiology team for referral. Going back to the medications, reconciling the medications is an important part of the RN role as well, because it helps avoid any potential side effects or adverse drug to drug interactions that can occur.
So, how is this information applicable in practice? Let's take a case of the 64-year-old female patient who works full time, who wants to continue to work without scheduled interruptions. No, she is healthy, no cardiac medications, she has good family support, and the blood pressure is 120 over 70 and no cardiovascular risk factors. However, with the initiation of the BTK, she developed hypertension. She was started on antihypertensive medications and she maintained her normal blood pressure. However, the patient developed atrial fibrillation. So, in this case, what would you do, like in terms of this patient who developed these uh, card- cardiovascular adverse event of atrial fibrillation?
So, when it comes to atrial fibrillation being a side effect, even in this patient who we used acalabrutinib, which is a second generation BTK inhibitor, we want to focus on getting control of atrial fibrillation. Now, getting control may, from a cardiovascular standpoint, mean rate control or rhythm control. So, this is a patient who would be referred out to cardio oncologist or cardio oncology APPs because it can occur in 6.2% of the patients on calbrutinib. I want to focus on controlling the rate first. And the main reason we're doing that is because the main rhythm control medications can actually have a drug to drug interaction with the BTK inhibitors. So we will often use beta blockers or digoxin in order to control the rate. Hopefully, by controlling the rate, you're allowing the patient to self convert back to sinus rhythm. But if their heart rates are controlled and less than 100, this is the patient who can essentially maintain therapy on BTK inhibitors in most cases. The other concern with BTK inhibitors is the bleeding risk when it comes to this patient who has atrial fibrillation. You want to use the CHA2DS2 VAS score to determine if this is even a patient who needs to be on blood thinners. If that risk score in a female is greater than 3, then you want to use anticoagulation. Fortunately, she doesn't have a lot of comorbidities. So her CHA2DS2 VAS score in this particular case, because of the new hypertension and her gender, is 2. So she is not someone who necessarily needs anticoagulation. However, in men, if their risk score is greater than 2, or women where their risk score of CHA2DS2 VAS risk score is greater than 3, they should be started on anticoagulation. You do, however, want to avoid warfarin, and it is completely avoided in our first generation, ibrutinib, but even in this particular acalabrutinib, often we're using our DOACs, such as apixaban, is one of the major ones that we're using for anticoagulation in patients that have elevated stroke risk. Monitoring very closely this patient who may need any type of blood thinner is important for bruising, bleeding, those types of things, in order to make sure that the combination of the BTK inhibitor as well as the anticoagulant is not causing any severe bleeding.
Thank you, like for explaining that. But let me ask you this: in practice, some of these patients are thrombocytopenic. Do you have a guideline as to how low your platelet before you can initiate these DOACs?
So there's no official guideline. Our practice here, we do typically hold DOACs if the platelet level is less than 50,000.
Hasana, thank you. And in that patient, given that the patient developed atrial fibrillation and still remain in atrial fibrillation after starting on that acalabrutinib. So, what other options would you recommend regarding this patient?
In this particular patient, we have to consider going to a third generation BTK inhibitor rather than staying with the second generation, as it has a lower incidence of atrial fibrillation, as well as a slightly lower incidence of bleeding.
Thank you for clarifying that. So, what are the 2 to 3 takeaways for listeners, like in this management of patients on BTK inhibitors?
It's always important that we're aware of the comorbidities and patient medical history when it comes to selecting a BTK inhibitor appropriately. You want to manage patients with a multidisciplinary team. So you're going to have the oncologist involved, you're going to have the cardiologist or the cardio-oncologist involved when it comes to initiating BTK inhibitors, especially in patients with any kind of cardiovascular history, so that they're aware of the side effects and you have the ability to minimize the cardiovascular side effects. Also, educating the patient about these potential cardiovascular side effects and the management of these cardiovascular side effects, if they do occur, is important. You want to know and monitor any of the cardiovascular side effects and possibly consider changing or discontinuing BTK inhibitors if there's any problems that are occurring that cannot be controlled while maintaining therapy.
Thank you, Hasana, for sharing these tips that will help us manage these patients effectively. Thank you.
You're welcome.
If you want more education on BTK inhibitors, visit the ICOS website at www.ic-os.org or the France Foundation education page at www.francefoundation.com/education. This resource was developed by leading experts from ICOS and the France Foundation to support providers and patient care. Tune in to other episodes in this podcast series where experts discuss the use of BTK inhibitors in CLL and associated cardiovascular risks.